Good afternoon, everyone, and welcome to the EULAR 2024 press conference. Thank you for your time, and I hope you enjoyed your congress so far. And we have a very exciting topics today to discuss with the panel presenting, and I will not take too much time of that. So my name is Yulia Kaliskan. I'm EULAR Communications and Communities Manager, and I will be moderating this press conference today for you. With that said, I want to pass to the EULAR president, Professor Daniel Alitaja, who has two exciting topics to present for you. And Daniel, to you.
Thank you, Julia. Also from my side, a warm welcome to Vienna. I think most of you are probably from Vienna, or many of you. At least I see some familiar faces. So thank you for joining the press conference in the room and online. You have my welcome note in the press releases, so I spare you from telling you how great our Congress is, because you can, first of all, see it here and feel the vibe of this great Congress that we managed after 20 years to bring back to Vienna, which is a particular pleasure for me being Viennese. It is a great Congress venue, and I hope you have the chance to really explore also all the offerings on the scientific part of the Congress. It is very difficult to choose individual activities or projects out of all the science that is presented. I chose to pick first of all the EULAR Impact of RMDs survey. This is my first abstract. It's an important activity for several reasons. This survey aims to address an unmet need in Europe, and that is to know about the impact that musculoskeletal and rheumatic diseases actually have on the individuals that are affected by these diseases and on society as such. By knowing the impact, we can start making a difference. If we don't know the impact, we don't know what we can improve. And that survey targets all patients across Europe with a baseline evaluation. It's an online form that they can fill out about their demographics, their musculoskeletal diseases, and how those diseases impact their life. So it's a very simple idea. You ask all those affected to fill in a questionnaire. And then you have a biannual follow-up of these questionnaires, so you can also understand how this changes over time in the secular trend, but also individually for those affected. This survey will make a big difference and a huge difference to our understanding of how to improve rheumatic and musculoskeletal disease, and it will give us a very important tool to also do appropriate advocacy action on the European level, on the different national levels, because rheumatic and musculoskeletal diseases have likewise or greater impact than many of the other diseases that have potentially higher interest or coverage by media. This is, in brief, this survey. I would like to, for all the reasons mentioned, draw your attention to this abstract. The other one is, again, one abstract that deals with a highly relevant disease from a socioeconomic aspect. It's osteoarthritis. Now, there's all these inflammatory diseases that are dramatic in rheumatology, and I could have chosen one of these. I decided to go for this osteoarthritis abstract because it is a very important one that looks as, in a large-scale European endeavor, a study that covers 3 million people in a cohort study and case-control approach to understand how these people are affected by comorbidities. We know that the unmet need for osteoarthritis patients is the management. First of all, we don't have good drugs, but also they don't have good care. If they don't have good care, that means they are not taking as much, are not as well taken care of for their comorbidities. And this survey really shows that a large proportion of these patients do have other musculoskeletal diseases like rheumatoid arthritis or polymyalgia and fibromyalgia. Maybe not at baseline, but they also develop it over time. So this large-scale study shows that this potentially misperceived disease as a not so dramatic and not so impactful disease, osteoarthritis, is actually affecting people quite substantially, and this somehow links also to the first abstract about impact of disease, but not only by prevalence, which is the most prevalent musculoskeletal disease, but also by the comorbidities that these patients carry and develop over time. So I chose this one to also raise the awareness on a potentially, in our field, a little bit neglected field of osteoarthritis, and a field where we are certainly still lacking effective drug treatments. So please take a look at this one, and if you are covering this one, you are reaching a lot of people that are affected, many of which are in the room, just simply by prevalence. Thank you very much. There were my two abstracts.
Are there any questions to Professor Al-Taha? Yes, we have a microphone. My colleague will just pass it, and please introduce yourself and you can ask questions.
Romain Loury from Egora Panorama du Médecin in France. How do you explain this lack of treatment for osteoarthritis? What are the obstacles?
It's mostly probably related to the nature of the disease and the pathogenesis of the disease, being not a primary inflammatory immune-mediated disease where we have a clinical, a clear process that goes wrong and that we can address. It is still considered to be degenerative, although there is inflammation on the local level, of course. Treatments so far have been very symptomatic. There are treatments currently being investigated for osteoarthritis that are disease modifying, but the other problem in osteoarthritis, and that probably also answers to some extent your question, is that it is very difficult to measure outcomes in clinical trials because it's a slow disease. Inflammatory diseases are, easier to address in clinical trials. You have inflammation, and you can see if inflammation goes back. Here, you have a process over time that is very difficult in particularly short-term treatments.
Any other questions? We can also have questions at the end if someone will find out something that they didn't during the press conference. So then we can move to the next topic. In next speaker, I am passing word to the Professor Loreto Carmona, who has an exciting announcement about the EULAR manifesto.
Thank you, Julia. On April 7th, we launched the EULAR manifesto. The EULAR manifesto is a list of solutions that we have compiled for the policymakers to tackle what we call the rheumatic and musculoskeletal disease crisis. And this list, we aim, it will protect the European citizens from chronic pain, disability, and even to prevent them having other non-communicable diseases that are with high mortality. It will also help to protect the workforce and the economy, and it will also protect the sustainability of the health systems and the social systems. And if you read it, in depth, this manifesto is taking the insights from all the affected ones. It would be the patients, it also the health professionals, nurses, psychologists, the rheumatologists, the pediatric rheumatologist, and I mean not only the prevalence of the rheumatic and musculoskeletal diseases, because we have 200 of them. Osteoarthritis is an example of a very prevalent one, but we also have diseases that affect the children, rare diseases, and also diseases that end up producing a lot of comorbidities and cardiovascular events and even cancer. So if And the problem is that this community, that it's almost invisible to the the policymakers, that we know it's a huge community, but it's invisible. This community has the tools to tackle these things. So we know how to treat them, we know how to diagnose them, we know how to make somebody who starts with a disease not to progress to a wheelchair. So we have a lot of things that we can do. Okay. Also, we work very much in multidisciplinary teams. Okay, and we are very cost effective. So all these messages we compiled so that the policymakers can then, produce legislation or to include us in their reports and to do very simple things. I mean, you have a list of the things that we're asking for, the list of asks. Just to give you an idea, one of the things that we ask to the policymakers is that they should prioritize the rheumatic and musculoskeletal diseases in the Healthier Together initiative. In this initiative, they only consider a number of diseases, right? But only the high mortality diseases, while right now, the sustainability of the healthcare is more about not the people who die, but the people who cannot work and the people who needs a lot of chronic care and needs to be, non-disabled. So this is just an example of what's included in the manifesto, and what we are doing is to present it to the different MEPs. We presented to the members of the parliament that were, in the past. Now with elections, we are going to present it to the new ones, with the hope that this, guide them into a better future for us.
Thank you, Loreto. Are there any questions to Professor Carmona? If not, then we can move to our next topic and our next speaker, Professor Andrew Cope, which will introduce the EULAR network of trial centers. Please, Andrew.
Good afternoon, everybody. It's really good to be here, and thank you for coming. You'll hear throughout this meeting that our prime goal is to make the lives of people with rheumatic diseases in Europe better. And there are many, many ways that we try to do that. One component of that is linked to research, and EULAR now has a research center, and I'm very pleased to describe for you a new initiative which we're going to put in place to try and support research, to support progress, and really in the end develop new medicines for people across a range of rheumatic diseases. Now, to achieve that requires evidence, and the best evidence comes from randomized clinical trials, and you heard a little bit about that in the context of OA from Daniel. Trials are expensive, they take a long time to do, and they are fraught with banana skins, regulatory banana skins, legal banana skins. Recruitment and retention is fundamental to the success of these. It was probably my mother ringing to see how I was getting on. I apologize for that. And the private sector and public sector really struggle with this because of the time it takes and because of the complexities of delivering studies. First and foremost, we need to recruit people into the studies. And one of the unique things about our organization is that we have an extended panel of patient research partners who are really keen to support these initiatives to do trials better, quicker, more efficiently, using the best outcome measures and the best design, where the private or public sector would come and say, well, we're thinking about a particular study, how should we do it? And the patient perspective is fundamental here, thinking about symptom burden, what really matters. And so this component is embedded in this initiative. And the initiative is the EULAR network of trial centers. And our strapline is stop searching, start researching. Your rheumatology clinical trials journey starts here. And the stakeholders are the private sector, so large pharmaceutical industries, biotech, but also clinical academics, like many of us here, who have important research questions that we want to address by implementing a really robust clinical trial design. Now, the way this works is that we have to recruit centers, because without the centers, we can't recruit people who are willing to participate in trials. And as of today, we're very pleased to report that we have had expressions of interest, formal applications, to become members of this network from nearly 150 centers. And we're aiming from upwards of 400 to 500 centers across 43 member states. The full application process will allow us to collect detailed information about the center's areas of expertise, the staff, the capacity, the technologies they have. It could be anything from imaging to taking blood samples to taking biopsies to support the clinical trial activities. And all of that information from what we hope will be many hundred centers will be put into a database which will underpin this network. So what the network is not a trial center, we're not a CRO, but we're providing the necessary infrastructure so that anybody can come to us and say, I want to do a study in this particular condition. Who should we talk to? And what we're hoping is that for the private sector in particular, they will have some nice surprises in the sense of a wide range of different centers who are willing to participate, who have the expertise, but who have large populations of people who would be willing to participate in these trials. Another key component of this is capacity building and training. We are really keen to support and train the next generation of clinical trialists. Clinical trials are really difficult to do, really difficult. But EULAR has the expertise and the technologies and the experience from many grown-ups, some of us are on the table here, who really can share that experience. It's an art as well. There is a certain skill about talking to someone and saying, we've got this research study, would you consider participating? And then explaining it in a way that really helps. And then linked to that, we hope to provide some clinical trials toolkits, which will be available to all centers, that will help speed up the sort of process of trial setup, because again, these things take a lot of time. And including in these will be things like some of the outcome measures that we use across multiple rheumatic diseases. We're in the process of establishing an outcome measures library, many hundreds of different questionnaires, and together with the patient research partners who will advise what outcomes we need to look at, we'll be able to implement those to get the best outcomes and to allow the medicines that are being tested to be submitted for registration and licensing. So please communicate this to your communities. Tell them that we're in business to do high quality trials and to support both sponsors in the academic and private sector.
Thank you. Thank you, Andrew. Are there any questions to Professor Cope? Yes, just a second.
Pierre Doal from Belgium, Orthorheumato. A quick question, but also difficult to answer, I think. You said more clinical trials, but these trials is so restrictive. The criteria is so restrictive for the patient. It's difficult to input to get patient in this study. I think not only in rheumatology, but in other part in medical research, it's so difficult for the patient also to hear no, you can't enter in this study because you have this comorbidity or this or this or this, and in rheumatology you have aging patients, for example, but also kids. And that's difficult. Also, pregnant women, it's also difficult. And we know that pregnancy and HLA, for example, it's really difficult. So how could you manage in the real world?
Yeah. So I think the way we manage that problem is to recruit a large enough number of centers who have expertise in these particular areas. And I think what really underpins the activity is quality clinical care. Because if you have physicians, principal investigators, chief investigators who really understand the complexities of someone with a rheumatic disease with the comorbidities that you talk about, or someone who is pregnant, then you're going to deliver higher quality studies in a way that is safe. I think historically, the private sector have focused on centers of excellence for obvious reasons. These are people who are super experienced. But these people are always super busy too, and they're doing the most trials. And so there is diminishing returns in terms of the cohort of populations that they want to recruit. And we want to change that. So by opening up the network to hundreds and hundreds of centers where the populations are extensive, that the training and the expertise is there, and EULAR can provide some of that, that will be in a much better position to do some of the more challenging studies. I make one other point. There are many rare conditions that historically have not been studied in randomized controlled trials. Why? Because of the numbers. A large network will give us opportunities to recruit those numbers and really get some useful data.
Thank you. Any other questions? Yeah, please.
Hi, I'm Eve Smith, a paediatric rheumatologist from Liverpool in the UK. I just wanted to ask, have you had many applications from paediatric centres, and would that be welcome? And sort of linked to that, and this issue around recruitment and rarity, is there expertise within entry in things like Bayesian designs, adaptive designs, that might make it easier to recruit these smaller populations of patients?
Yep, so thank you, and welcome from Liverpool. So this is exactly what we want to do. So think about design. I mean, basket trials, Bayesian design, where there is expertise both in the private sector and with collaborating academic centers. So that is right up there. Now, you mentioned the pediatric community. Now, the first person I talked to when we were thinking about this was this guy sitting next to me. And he said, get onto Printo. So Printo is an amazing network of pediatric centers that have been going for 20 to 30 years. They have, I think it's 700 centers globally, and they operate more as a CRO. Now, that would be a dream for us. We're going to start small and scale up. We have encouraged our colleagues in pediatric rheumatology to apply to be part of entry, but we will always make sure that any sponsor who is interested in prosecuting a pediatric trial to also engage with Printo. So we're going to work in collaboration, but we have to cover that population for sure.
Nice to hear.
Thank you. Any other questions? Yes, please.
Hi, thank you. Abby from EMJ in London. It sounds like a fantastic initiative. I was just wondering, it's rather a broad question. What are you hoping, which areas of rheumatology are you hoping to tackle first with the trial centres?
Well, if you're going to ask me which areas we're going to cover, I would say all of them, and some ones that we haven't had a chance to tackle before. My current view is that we need to road test the network. Because when a sponsor comes to us and say, we want to do a trial in X, we have to engage the community to say, this is a really cool study. We need to get involved in this. It's also possible that we'll get some studies which we think, we've kind of done that. Or we may talk to ELSA and they may say, actually, this is not what you should be studying. I think we're open to all sorts of suggestions. We want to try and roll out the network with something that we can test so that we get those communications going. My fear is that it might end up being something common like an inflammatory arthritis, but the interest from the stakeholders in the private sector almost universally has been the more complicated conditions, connective tissue diseases and lupus, because these are also really difficult studies to do, difficult to recruit numbers because you're looking at subsets of a less common condition. But we're open for business, so we'll consider lots of things. Pain, I think, is another big area that we want to cover, and fatigue.
Thank you. Any other questions on this topic? If not, then we can move to the next one. And I'm happy to announce Dr. Elsa Mateus, Vice President PARE, and she will be presenting the topic on transition from pediatric to adult healthcare. Please, Elsa.
Thank you. Let's see, this is good. Okay. Well, good afternoon, and thank you for being here. Well, it's not easy to select some topics to address here, but we really aim to call your attention about the problems of raising awareness and on childhood arthritis and RMDs, and also on transitioning and in healthcare. So, as we all know, community awareness that children and young people get arthritis too and RMDs is still low. And this leads to delays in diagnosis, worse clinical outcomes, stigma and isolation, mostly for the ones suffering from the conditions and also for their families. So considering the relevance of this topic, there were some sessions on childhood arthritis that were included in the Congress, and I will address two of them, two of these abstracts. There was one presentation from Juvenile Arthritis Research, which is a patient organization in the UK that is involved in a variety of projects to raise awareness and support also juvenile idiopathic arthritis patients and their families. And their initiatives, they have several projects from websites and social media campaigns to bookmarks and information packs for schools. And they also included large-scale information posters in buildings, which is something very innovative to call attention to the problem. So why these projects are very interesting? Because they are low cost, and we know that patient organizations usually strive with funding and resources to be able to promote their initiatives. So these ideas can also be replicated in other areas. And they are providing good examples on how to deliver key messages that are based on high quality and verified clinical information. And they are also taking advantages of the innovative approaches. This is something that we really need when we want to call the attention to these new issues or more ignored issues. So these initiatives were very successful, as you can see. And hopefully they will contribute to raise awareness and to reduce the delays to diagnosis, and then lessen the burden of loneliness and stigma in the population of people affected by arthritis in children and young people and their families. But alongside also with this need of raising awareness, there's also the need to ensure an effective transition between rheumatology pediatric care and from the young patients that transition from the pediatric care to adult care, which is also crucial. This, as we know, is a very important moment in an adolescent's development direction. So it's a crucial moment when they start to take over their own lives. So there was this very interesting work from the Italian researchers that explored the transition from pediatric to adult care, and based in a survey of patients aged 14 to 20 and their caregivers. So this work highlighted, for instance, that one of the main obstacles that families and patients face in this transition from pediatric to adult rheumatology is a lack of clear information on the process. This is often unstructured communication between both rheumatologists, and there is also therefore a risk of interruptions of therapeutic continuity. And up to 30% of caregivers in Italy from the survey felt they did not have complete information on the transition processes. So this is a very crucial area to work on. As for the patients, there were 3 critical areas identified. which are also very meaningful if you consider that usually transition is around 18 years old. One is the bureaucratic aspects that make the transition processes excessively long, and if you're not used to deal with bureaucratics at 18, it's not easy for sure. And also the insufficient communication and coordination between the pediatric and adult doctors, the same problem here. And last but not least, there are also emotional and psychological aspect around the need to adapt to new medical environment, and of course to take the responsibility for their own health, which sometimes may lead to increase the feeling of loneliness and being left alone in the system. And in addition to this, I also would like to highlight that in line with these issues around RMDs in children and young people, the Edgarstein Prize topic for 2025 will be growing up with an RMD, learning, transitioning from pediatrics, and the impacts on childhood and the family. So this is a very important issue. We need to address this and to call more attention upon these problems. Thank you.
Thank you, Elsa. Are there any questions? Not. If not, then we move to the next topic. And I'm happy to introduce Dr. Mdi Bindozi, EULAR HPR Committee Chair, and his topic on enhancing psychological well-being in patients in using digital health apps. Please.
Hello, everyone. Thank you very much for coming. I'm a health professional, and our group consists of a lot of professionals, physiotherapists, occupational therapists, nurses, pharmacists, and others. And one of the issues that really concerns us is about holistic care. So we know that there's strong evidence to show that people with rheumatoid arthritis, which have also comorbid psychological distress like anxiety and depression, have got really, really poor quality of life in addition to disease activity. Therefore, we know that the current medications are very good at addressing disease activity, but not necessarily addressing the quality of life in terms of mental health or anxiety or psychological distress. So one of the work that we do within health professionals is to develop non-pharmacological approaches, non-pharmacological interventions. And one of this abstract that I'm looking at, they developed a digital health application to address psychological quality of life in people with rheumatoid arthritis. And when you develop intervention, it's important to make sure that they work. Therefore, this abstract or this work was to evaluate the quality, to evaluate the effectiveness and safety of this digital intervention called Reclarit in adults with rheumatoid arthritis. This is a German study. There are a lot of other studies, similar studies across different countries. So to evaluate the effectiveness of this intervention, they did a randomized controlled trial where patients received these digital health interventions in addition to their normal care. And then the other group received just normal care alone. And they measured psychological quality of life by using SF36. This is validated patient-reported outcome measure, which looks at the physical function and also psychological function in people with rheumatoid arthritis. Looking at the outcomes after 3 months, those people who received this digital health intervention really had a really good mental health in terms of quality of life, in terms of SF36, the mental component of this questionnaire. And those who received standard care really did not have any improvement in that regard. So there were some other secondary outcomes such as depression, anxiety, fatigue, social function. These also improved in those people who received the intervention. But those other outcomes like pain or physical function did not have any improvements. Therefore, the conclusion was that this intervention was really effective at improving quality of life in terms of mental health for people with rheumatoid arthritis. The really key message here is that people need both pharmacological and non-pharmacological interventions in order to provide that holistic care for people with rheumatoid arthritis. We've got a whole abstract session tomorrow looking at digital health. These results are really reflected across other studies, like a really study by Dr. Linen Nuxen tomorrow, also looked at 12 months effects of novel digital patient education, which also shows the same evidence that these interventions can improve self-management in people with early rheumatoid arthritis. And therefore, the key message here is that patients need both pharmacological and non-pharmacological interventions. Thank you.
Thank you, Mdimi. Are there any questions to Dr. Dozie? Not? If not, then last but not least, we move to Professor Dirk Foyle on topic Advancing Pediatric Rheumatology Diagnosis and Treatments. Please, Dirk.
Yeah, good afternoon, and also warm welcome from my side. I can say that as a pediatric rheumatologist, I'm really extremely grateful that EULAR has children as one difficult population with rheumatic, also affected by rheumatic diseases, that much in its focus, and this is really represented also here by others in the press conference already. It is estimated that maybe 1 in 250 children in the EU, in Europe, is affected by any kind of a rheumatic disease. It's often inflammatory diseases. About half of those affected are affected with joints, but there's then arthritis as a prominent component. But the other half, they then have systemic inflammatory diseases of different tissues, often quite complex and absolutely not easy to diagnose and treat. And we already heard from Elsa the awareness component, so a lot is done to raise awareness, to also then achieve a reduced delay in diagnosis, because the earlier we diagnose, the earlier we treat, the more we can prevent organ damage. But still it is difficult in many cases. And the two abstracts I was picking actually deal with that, the diagnosis and then how to treat in a more targeted fashion. The first one is dealing with a systemic disease called Sjögren's syndrome. This is more common in adults than in children. Clearly, it's a rare disease, and in children, this is an example that it presents different from adults, often. So it's an autoimmune disease affecting multiple tissues, but especially salivary glands. And in children, you often do not have this dryness in mouth and in the eye. You have the parotis gland as a prominent feature affected in children, coming and going. And this can appear with Sjögren's syndrome or without. And so it is not so easy to diagnose, especially in those who do not have prominent autoimmune features with autoantibodies. And this work shows a new laboratory test as a diagnostic procedure, the interference signature. So you measure the activation of a specific immune pathway. Here you can do it in blood. They also did it in the gland itself and showed that these processes are active. And this can actually be used and introduced in clinical practice, not only in patients with Sjögren's syndrome, but in also children actually as a new diagnostic test. And that's a major advancement, of course. And then the second abstract deals with therapeutic and outcome measures more in another classical autoimmune disease, lupus, systemic lupus. But in children also often not easy, of course, to diagnose, presenting untypical, if you wish, and not easy to treat. And there are now recommendations for treat to target, a better targeted treatment also in these patients. And this work dealt with organ damage development in patients depending on disease activity status, and also treatment approaches, medication that was used, And it found that actually, especially, which is not surprising, in those with higher disease activity, you have a higher proportion of children with organ damage. It's 28% around, and a lower proportion, but still 20%, which is 1 in 5 in those with obviously rather mild or low disease activity. And in both populations, the use of corticosteroids was a factor that was obviously associated with the generation of organ damage. This is pointing to the fact, or giving us at least as pediatric rheumatologists reason to believe using treat to target with more targeted therapies, reducing the use of higher dose steroids in these patients for longer term is important and will be a way in the future and to foster treat to target strategies. So 2 important abstracts that show what we actually do and where also, I think, major achievements have been made in diagnosis and treatment of children with rheumatic diseases. Thank you.
Thank you, Dirk. Are there any questions to Professor Foyle? If not, that we are almost there. We've been brief, but we have interviews scheduled. So thank you once again for being here. Enjoy the rest of the Congress. We see you at the press office. But those who have scheduled interviews, please find me and we will proceed with that. Thank you, everyone.